According to Caldwell Esselstyn, and I quote, "If the truth be known, coronary artery disease is a toothless paper tiger that need never ever exist, and if it does exist, need never ever progress." A bold statement for many to consider, but as we've learned during the series, diet and lifestyle are indeed the tools that help people heal from and prevent many forms of cardiovascular disease. Tonight's special guest is Dr. Koushik Reddy, a plant-based interventional cardiologist who will share his knowledge as to how all the cardiovascular risk factors are preventable via healthy living and eating. Good evening, everyone. I'm Jim Spellos from Plant-Powered Metro New York, and along with my co-hosts Judy and Ben Mertens, we welcome you once again to this episode of Heart to Healthy Heart, plant-based conversations that can save your life. As always, we encourage you to use the chat box, tell us where you're viewing from, and as well to ask as many questions as time allows. We have 30 minutes. Hopefully, we'll be able to get in as many as possible. Let's not delay anymore. Let me introduce tonight's guest, and we really appreciate him being here. Dr. Koushik Reddy is Director of Interventional Cardiology and Assistant Professor of Medicine at the University of South Florida James A. Haley VA Medical Center. He earned his medical degree at Gandhi Medical College in India, completed residency as chief resident in internal medicine at Jamaica Hospital in Queens, right down the road from me actually, and completed fellowship trainings in cardiology and interventional cardiology at Winthrop University Hospital in Mineola, New York. His board certifications span cardiovascular diseases, interventional cardiology, and lifestyle medicine. In 2019, he founded Plant-Based Lifestyle Movement, a Tampa area community-based nonprofit organization that is working to take the power of plant-based nutrition and lifestyle medicine to the grassroots level. Dr. Reddy, it's an honor to have you here as a guest tonight. Thanks for being here.
Thank you. Really appreciate the opportunity, and thank you for having me on tonight.
My pleasure. So talk to us about all the current burden of cardiovascular disease and how risk factors are indeed preventable.
So I just want to kind of go through a quick timeline in history, in as far back as 1962, when the U.S. Surgeon General first declared smoking is injurious to human health. It took about another 10, 12 years, maybe even 15. In 1978, there was a major meeting held in Bethesda, Maryland, the World Congress of Cardiologists. Everybody got together and said, we really have to do something from a public health promotion point of view to lower cardiovascular disease. And because of that one singular, policy-driven agenda, we have made a tremendous progress in cardiovascular disease burden compared to 1970s to as recently as up to 2010, 2011. And if you continue this exact same curves that kind of went on a declining path, continually declining path for almost 3+ decades, but in the golden era, what people like myself in this field of cardiology and interventional cardiology and doing all the fancy procedures and advanced care in the coronary care units, what is considered kind of a golden era is the past 10 to 15 years. And if you look at those curves of cardiovascular mortality, stroke mortality, congestive heart failure mortality, the lines have pretty much plateaued. We were hardly able to lower even a single % of cardiovascular morbidity and mortality in the past 10 to 12 years. And on top of that, congestive heart failure has now become one of the leading diagnoses, if not the leading diagnosis, admission to a hospital. And the way I look at it is that my generation mostly, and a generation before me, within the field of cardiovascular medicine or medicine in general, we have perfected the art of converting acute myocardial infarction or an acute heart attack into a chronic disease instead of channeling all of our talent and skill sets and intelligence into preventing it. And society at large, medical community, from a personal disease burden, and not to mention from a financial burden point of view, we're all paying the price. To summarize all of this in an updated version of cardiovascular disease burden and the risk burden, 2 papers were published very recently in JACC, in the Journal of American College of Cardiology. And the editorial that went with it, appropriately so, was titled "A Population Level Code Blue." Just let that sink in, folks. We are openly accepting it, that we are in a situation. Entire society is now going through at least from a cardiovascular perspective, a population level code blue. And subsequently, just 2 days ago, new data came out that is projecting, cardiovascular disease and the related risk factors, how they are potentially and likely to grow between 2025 and 2060. The prediction is diabetes is going to grow by an additional 40%. Obesity is going to grow by another 18 to 20%. So the current paradigm is just not sustainable, especially knowing extremely well that most of the cardiovascular risk factors, the related disease, the related morbidity and mortality are preventable. Yes, many times people need certain medications, even from a preventive point of view. But even before prevention, before primary prevention, there's a concept called primordial prevention. Some of you may have heard that. For those of you who have never heard the term, it's an old term, and the World Health Organization coined it 30 plus years ago, which is why work on nutrition and lifestyle when hypertension, obesity, diabetes, and high cholesterol show up. Why not start as early as possible and never become a hypertensive in the first place? So that's the concept of primordial prevention, is don't even accrue a combination of risk factors. So it is a very concerning and alarming statistic, but we have to start somewhere. And for my share, I run a cath lab, and I'm in the CCU, the director of the CCU. I do a lot of these procedures and take care of some of the sickest patients. But we have to prevent this. There's really no other way. We have to spin these wheels of prevention like literally it's like our last ride.
There's incredible amounts of information that you just shared with us right there. What I want to do right now, Dr. Reddy, is actually pass it over to Judith and Ben for a couple of questions, as we're getting questions coming in from the audience. So, Judith, I think you have the first one for the doctor tonight.
Yes. Good evening, Dr. Reddy. It's so good to be with you. So I've heard you say in some of your talks that people today are living longer, dying longer. Can you just tell us what you mean by that?
Sure. Yeah, I kind of bring that to everybody's attention as one of the opening slides in almost all of my talks. So if you go back 100 years ago, an average person in this country died around 45. That was the life expectancy in America exactly 100 years ago. And there were various reasons, because, be it lack of access to universal vaccination, infectious diseases, not having invented some of the antibiotics, or, public sanitation, clean drinking water, all those things. And we kind of take those things for granted. And then for all those combined reasons, an average person now in America lives to be 78. Phenomenal progress. But the unique beauty with that is that such a proportional degree of increase in life expectancy is not uniquely American. The same thing happened literally all over the world, including in some of the poorest of the poor countries. Compared to 100 years ago, people are living much, much, much longer. But sadly, if you plot that graph, the reason, one of the things I always ask my patients, friends, and family, or even my audience is, why do we actually want to be healthy? And then those answers almost always fall into two reasons as to why any one of us want to be healthy. One reason is quality of life, and the second reason is quantity of life. But in terms of quality of life, each one of us will define it differently. For one of you, it may be wanting to go back to run a marathon in your 60s. For the other person, the quality of life may be just being able to walk from the front door to the mailbox without having to deal with the diabetic severe neuropathic pain. Right? And then if you plot those graphs from quality against quantity, today's curves looks like a very bizarre convoluted shape, from down the slope of which, from very early on in our life, we are accumulating disease burden, such as childhood eating habits related to childhood cardiovascular risk factors. We can do an entire discussion for an hour on the concerning and alarming accumulation of risk factors in children. Obesity and type 2 diabetes is something that at least I have never heard when I was a medical student, that the type 2 diabetes is a possibility. So because of all these diseases accumulating early on, yes, we are living longer, but we are also dying longer, which is coming at the expense of losing good quality of life. So that can be quantified. Epidemiologists and people in public health quantify this as disability adjusted loss of years, meaning that how many years is our average Americans losing while they are living longer, losing their life to lack of quality. It turns out to be the average is a shocking number of 23.6 years. And as shocking as the number may sound, that can't be true. People are losing a quarter of a century. Just look around. Talk to your friends, talk to our parents, some of ourselves. Yes, I'm alive, but I'm not at my dinner table with my family for Christmas or Thanksgiving or any other religious holiday because I'm being tube fed in a nursing home because of hypertension-related stroke, which is preventable in a majority of people. I'm not even able to go take my dog, a family dog with the grandkids down the street for a walk because my feet hurts, or I just got an amputation because of a peripheral vascular disease. Or I'm not on a cruise ship because I'm on that dialysis machine due to combination of hypertension and diabetes, which in a majority of people is preventable. So that's what I mean, kind of a long-winded answer. I'm sorry about that, but what do I mean by living longer and dying longer? Instead, what I argue is that by taking care of simple things, inexpensive simple things, most of us, even in the setting of a high genetic risk, right, can live as good a quality of life as possible. Yes, sometimes you will have events. Sometimes we will have need for medical procedures, and that's all part of it. But like Dr. Kim Williams said, one of the previous guests here, I love that saying from Dr. Williams is that I'm not afraid of dying. I just don't want it to be my fault.
Impressive. Dr. Reddy, what is your role as an interventional cardiologist?
So that's my, it's interesting. So that's my primary job. I'm trained as an interventionalist. I'm the director of the lab, and I do procedures. I did a bunch of them today. And my role is to do all types of coronary, vascular procedures. And that's my primary modality of my line of work. But I'm also an interventional cardiologist. And for those of you who don't know, if you were to train in the US system to become an interventional cardiologist, when I was in training, it's about 15 years of continuous uninterrupted training after high school. Now it's 17 years. So during those many years of training, especially once you enter cardiology, we spent a lot of time in the deep, dungeons of lead-shielded cardiac cath lab doing procedures. So it's unusual for someone like myself to step outside the confines of a cardiac cath lab and make a humble plea, first to myself as a professional to reinvent myself, and two, to my colleagues, my friends, my family, now to the society at large is, as experienced as I may be, as talented as I may be, don't meet me there. Don't meet me there. So to convey that message, believe it or not, I am the crazy interventional cardiologist who walks the floors of the hospital wearing a scrub top that reads under my name that I have a carrot and a stent. You pick. All right. How is that for an interventional cardiologist, right?
Yes, and so that really leads perfectly into my next question, which is, was there any particular thing or time that you can remember that motivated you to leave the dungeons of the cath lab? And I've been there. It's cold, and it's to go outside and to make your humble plea to your colleagues. What motivated you?
So one, I haven't left the cath lab. I'm still in the cath lab. I am actually the director of interventional cardiology. I'm teaching. I teach. I work with the two interventional fellows today. We're teaching them how to do these procedures. But I don't have a personal compelling story, not from either my personal health reasons or a family health reasons. It was one of those just random, bizarre days about, I want to say now, almost 6-7 years ago now. On a day, what I call routine, I did a bunch of procedures, sat at my desk, and routinely, mundanely, as a habit, as a trained professional, I should say, was just going on with my business of compiling and completing patient procedure related, notes and charts and the related, reporting. And then it's not like I detected a new pattern that never existed. It's the same old pattern. But that day I questioned it, and I have no idea why I questioned it. It's a true, honest story. I just, my question was, if I am treating, in a full academic medical center with trainees, research, all kinds of going on, high blood pressure, diabetes, high cholesterol, and we are quote unquote counseling patients to, eat healthy, whatever that meant back then to me, and lose weight and be active. If you're all doing all these things, why are such a high proportion of patients whom we are treating to goal are still needing my services in the cath lab? Isn't the very idea of treating them is never to have these events, at least in the most part? But and that's what kind of made me question: is this actually how we treat this disease that I make a living off of? So I literally stopped doing my work, and I went through a little bit of a contemplation and introspection. So back then, my wife used to work for the VA as a primary care doctor. I picked up the phone and I called her. I said, "Honey, look, I'm having an interesting question." She goes, "What is it?" "I think I'm questioning my entire professional paradigm. I think I got it wrong. This is not how we treat this disease or the risk factors." And she said to me, "Honey, we got a name for this. It's called midlife crisis." So yeah, that's how it started. What started as a more of a personal inquiry towards my own profession led to a deep passion. And because all of this was not known to me, because besides talking to a patient and the family and say, "Hey, go home and eat healthy." Besides that, I really did not know the data, actually, how to counsel a patient. Because even if you acquire the knowledge and acquire the data, the most important skill is behavioral modification, something that us doctors don't get taught, right? It's easy for me to, come across a patient who has had a heart attack, wants to make changes, and I'm, go on rattling about, got to sleep 8 hours a day, got to work 30-minute walk, and 6 or 7 the pillars of lifestyle medicine. But when the rubber hits the road, making that behavioral modification is very difficult. That in itself is a huge skill, and it took me about a few years to say that I kind of have that skill now. But the past 6 years of, while I continue to do what I do as both as a director of the interventional cardiology and the CCU, doing procedures and taking care of some of the sickest of 6 patients, is about how to prevent them from ending up there and how to make them see the value in the pillars of lifestyle medicine without ever diluting the essence of contemporary and evidence-based medicine. And those 6 years of learning how to find the balance have been the most rewarding and frustrating years of my professional career. Yeah.
Thank you. Thank you for that.
Dr. Reddy, can you tell us about any successes with patients in your practice who have adopted whole food, plant-based diet?
Oh yeah, absolutely. The phenomenal stories, and we're trying to put together as a, these are all anecdotal, and again, while I say stories, in the hierarchy of science, a case report, somebody saying that, "Hey, this thing happened to me." So yes, it is great. It is, makes us think, "Oh wow, what is here?" But usually, case reports are, here, if you ask me, patient-related stories in the hierarchy of medicine are at the rock bottom, meaning they're considered the lowest order of evidence. But that being said, the reason I like sharing stories is because we make a lot of our decisions in our life based on stories. Sometimes we become who we are based on stories. So it's extremely important to get these stories out that, people who struggled with insulin injections, people who struggle with 4 to 5 blood pressure medications, somebody like me shows up on a, virtual call because of COVID, counsels them, gives them some PDFs, and they see the value in it. And, 3 months go by and they pick up the phone and call you. And this, 70-year-old combat veterans from Vietnam are crying on the phone because they're no longer taking insulin because somebody opened up the door for them and something clicked. So there are countless stories like that. We know veterans who are not able to walk from the front yard to out of their neighborhood without having to pop a nitro pill are now running half marathons. Yeah, and the diet is only one part of that equation, and we taught them how to meet with like-minded individuals. because social support is extremely important. And that's what this program is all about, is to get this message to as many people. People lean on each other, seek support, because without that, and that's one of the things that the program that I run at the hospital. And yes, we talk a lot about plant-based nutrition, or the healthiest possible way of eating, but the foundation of our program is actually social support, either through the medical care system or through the community. So because of a combination of all of that, yes, there are phenomenal stories.
Yes.
And so that this is now, it's not even kind of my message that is uniquely different. This is a gold standard, evidence-based contemporary practice, meaning every Wednesday we meet with our entire team, cardiologists and cardiac surgeons, and we discuss these complex coronary intervention procedures. And almost invariably, unless it is an emergency heart attack, unless the pumping capacity of their heart is going down, unless there is a blockage in a location called the left main, guess what everybody says? Has this patient completed a 6 to 8 weeks of therapeutic lifestyle program under Dr. Reddy's supervision? If not, why are we opening the man's chest? Right. So this is not some crazy in the silos type of practice. This has now become the mainstream, and not because I'm driving it, but the evidence and the contemporary medical guidelines suggest that all of these interventions should be done only after a strong contemporary evidence-based lifestyle strategies and medical therapies fail.
Would you briefly describe for us the 6 pillars of lifestyle medicine?
Yeah, the 6 pillars of lifestyle medicine is, there's no particular order, but the way I see them in an order is that, in terms of an order of hierarchy, if you want to call it that, is social support. So that's number 1. The next number is stress reduction and mindfulness. Third one is sleep. Fourth is toxins, alcohol and tobacco. And fifth one is physical activity. Sixth one is nutrition. Those are the 6 pillars.
Is there a reason that you put nutrition at the bottom of the list? Do you think
Not necessarily? As I said, I kind of put, because the reason I say that is that it's, at least in my counseling of close to 2,000 patients at the hospital as a part of a 6-week group session, what we have noticed is that unless we connect the dots in that sequence, that we offer them, a lot of people living alone, they don't have means to cook, that they don't even know how to cook, and then I show up and say, you need to learn how to eat sweet potato and broccoli for breakfast. For them, it's such a foreign idea. But once we offer them support, whatever the stressors are in their life, we take them away, at least we show them here we are to help the system, or, look, there are neighbors within your own community who are doing this. Go to these events and learn these skills. And then it kind of becomes a nice blended equation because we know that, lack of social support is a direct causal link for heart attacks. Lack of sleep is now officially got added as the 8th pillar by the American Heart Association just a month ago as a direct causal link for heart disease. So the way I see this, like I said earlier, I don't necessarily see them as a hierarchy which goes first. I just name them that way.
Right.
And also depends on where the patients are. If a patient comes and says, doc, the main reason I'm not able to adapt this is I just don't have support. I don't even know how to cook. And then we have to prioritize the hierarchy of those 6 pillars a little differently without ever losing the sight that you got to nourish your body the right way.
Mm-hmm.
Let me take it from here, because I know we have a couple of questions from the audience, and we still want to make sure you talk about PBLM and the work you're doing down there. But we've gotten 2 people who've asked some very similar types of questions, which is, about why food isn't necessarily fixing their problem. So somebody said, LDL, what could make the LDL go up 25 after we dropped 100 points eating the same way? Is that something you see oftentimes in patients, or is it usually triggered by one of the other lifestyle pillars?
You would not really, LDL going up there are so many factors that can do it. The age of the patient, did the patient transition into a different hormone, menopause, postmenopausal status? thyroid status can affect LDL situations. And sometimes, people do have a lot of plant-based people who are, they swear by, I don't touch, any animal products. I'm eating as clean as I can. And yet my LDL is not dropping. There are so many locations there could be genetic mutations, including, how the gut absorbs your cholesterol. And, some of us, even the tiniest little amount that is in the food is saturated fat gets sucked in, and vice versa. And there are some people who, no matter how much they eat, they just don't absorb. And then, so there's a huge, many reasons, unless I look at the details of the blood profile, or sometimes we may even have to do some special testing to see why LDL would continue to go up. So usually I won't be able to give like a one simple answer and say this is the reason why your LDL went up, because there's so many factors that affect it.
Yeah. And another question that came in also about cholesterol being high and had an ultra fast CAT scan, arteries are clear. So is it okay? Is it normal to have high cholesterol while still having clear arteries?
Yeah, so it depends on when we see it. Meaning that because this cholesterol-related heart disease is not something that happens between last month and 3 months from now. This is a very slow process that happens over the course of many years. So if you have high cholesterol and if you have other risk factors, if you have a negative calcium score, all that it means is that, yes, you're being lucky. The disease has, is probably there, but you don't have enough of a calcified disease, right? That doesn't mean that you don't have plaque. All that it tells you that you don't have plaque that already built calcium inside of it that is not visible on a coronary and on a calcium score, right? So you have to also look at other risk factors. What is the cholesterol numbers? How long have they been high? And another way of quantifying this is that there's a beautiful way, it's called officially in medical terminology, it is called cholesterol years, meaning that you take your LDL, the LDL cholesterol, and you multiply that by your age, and you'll get a number. Let's say you're 50 years of age and your LDL is 100, that number is 5,000. So it should never be more than 5,000. So I'll give an example. I'm 52 years of age, and my LDL without any treatment is usually 47. Right? So one of the brightest minds in this field has recently written a paper kind of outlining all of this. Assuming if I do everything right and I live to be 100, I'm just randomly throwing out a number, even at 100, that product of my LDL and my age would still be just barely at 5,000. So if you do that, it is biologically possible, based on what we know now, you can live to be 100 without suffering a cardiovascular event. So the thing with LDL is that no matter what your cholesterol numbers, no matter what your CAT scan numbers are, the thing with LDL, it is causal. It causes heart disease. To keep it as low as possible for as long as possible by whatever means it takes.
So as we're about to wrap up, and the 30 minutes went so fast, I know you've been involved in PBLM. So can you tell the audience about what you're doing and what that organization is all about?
So PBLM is a nonprofit that my wife and we got together with a bunch of local area leaders, people who run restaurants, schools, and, churches and other religious organizations. And the main idea behind that was that every time I go to medical, lifestyle medicine meetings or plant-based nutrition meetings, I'm usually in the confines of, like-minded individuals, like-minded professional, passionate people from, all other, healthcare workers. And then the reality, when I come back home and I start going to work, between my home and my work, there are at least 30 fast food, junk food restaurants. The question that bothered me is that, yes, I'm talking to everybody in the medical community, but who is taking this message to the precinct? Who is taking this message to an elementary school teacher or the kids and their parents? So we quickly, put out a Facebook invite, and we met the people who are, like-minded, and we formed a board and we became a nonprofit. And soon after, we got hit with COVID. But even during COVID, we've been holding some Facebook events, and every February, I invite some of the leading, thought leaders in the world of plant-based nutrition and cardiology to come and do a labor of love. We run four Saturday lectures on Heart Healthy Month. So yeah, basically it's a nonprofit organization whose mission is to take the pillars of nutrition, evidence-based clinical nutrition, and lifestyle medicine as a labor of love and to the community, so they don't end up in my cardiac cath lab.
We can hope they don't. And we're going to ask one more question because two of the same came in. So let's get a quick answer, if that's ever possible, about calcium CAT scans. Is it only a snapshot in time, and should people do one as part of their regular physical?
No, don't repeat CAT scans. Don't repeat CAT scans. Just do one. Two things that just, if you want to check, if you think you're at a high risk, lipoprotein little a, check with your doctor, get it once. Don't pay for it. Don't waste your money repeating it every year, because it is almost entirely genetically determined, and you know that once. And there's really not much you can do to lower it. There's some drugs that are being tested, except for there's one study by a plant-based doctor out in Houston, tested that in African Americans on a plant-based diet. In that one subgroup, it may drop by 10 to 15% points, but really we don't have outcomes data. Calcium score, once you know it. But the reality though, because what I'm going to tell you based on that, I'm going to tell you exactly the same thing, is eat a predominantly a plant-based diet, if not an exclusively plant-based diet, and do all the other things right with your lifestyle, because I'm not going to tell you anything differently. So CAT scan has its value, where it can be used as a risk enhancer for either medical decision making of certain kind, or to initiate statin therapy in a high risk patient. It helps, but there's really no need to keep on doing it as an annual physical. Just unnecessary exposure to radiation.
Dr. Reddy, it's been an amazing half hour. Let's give one more plug for pblm.org, and thank you for all the work that you're doing, and thank you for your time tonight to share all your knowledge and expertise with us. We really appreciate it.
Thank you. Thank you for having me, and wish everybody in the audience a happy, healthy holiday season, and best of health and best of life.
That's what's important for us all. We are now going to go to next week. We've had some amazing doctors as guests, and we're thrilled to say that's going to continue in November as we welcome Dr. Michael Greger as our guest on Thursday, the 17th of November. We are so excited. It's the beginning of the Plantathon month for Plant Powered Metro New York, and he's going to be here. And I don't think that Judy, Ben, or I are going to have any time to ask questions, because everybody else is going to want to. So if you want to watch any of our episodes again, they're all on the Plant Powered Metro New York YouTube channel. On behalf of Judith and Ben, again, I am Jim Spellos. We are so happy that you are with us. We wish you optimal health. We hope that we see you again in a month's time right here on Heart to Healthy Heart. Take care.